anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Okay, now the first award is... What's
nothing, I don't know.
We have had a 40% caesarean section rate in the National Maternity Hospital. That is major abdominal surgery.
Around 40,000 mums did not return to work in 2022. It's even more relevant if you're a mum who's experienced birth trauma.
We spend more money on litigation than we currently spend on the maternity services. It's bonkers.
It's in all of our interests, and particularly the government, to improve maternity services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution needs to happen. We need to start working together.
I know it's a hard time, but for goodness sake, it's the best profession in the world.
Be proud to be midwives, be proud of the job that we do, and continue to celebrate our successes.
Midwives make a difference to women every single day, and let's not lose that. It's more important than anything.
Welcome to Matflix, video streaming from maternity experts. My name is Dr. Jenny Hall. I am the box set's curator at Matflix, a fellow of the Royal College of Midwives and a former editor of The Practising Midwife. At Matflix, we bring together videos of talks from top maternity experts into box sets to support your continued professional development, study and revalidation. It is a perfect study accompaniment for midwives, maternity professionals, midwifery students and anyone thinking about a career in the maternity services. My job is bringing together the latest thinking area by area so you do not have to. Not only do you get the video of brilliant talks and relevant content in thematic box sets, you also get access to the audio version so you can listen on the commute or while you walk the dog. Plus links to the latest research in the relevant field, government policy documents, the presenter's PowerPoint and more besides. Sign up to Matflix now for the best video streaming from maternity experts.
You're thinking, but I've never read about these midwives in the Bible, and that's because they didn't make it into the Gospels. Why was it that we nurses, midwives, seem so invisible to the doctors, to the media?
An amazing midwife said to me, you can't be what you haven't seen. These are the world's most researched probiotic, and we can say that with confidence because we've done over 300 clinical trials on this little bottle of goodness.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever,
where they think that person's a real trailblazer.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators. Anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Okay, now the first award is... What's
nothing, I don't know.
We have had a 40% caesarean section rate in the National Maternity Hospital. That is major abdominal surgery.
Around 40,000 mums did not return to work in 2022. It's even more relevant if you're a mum who's experienced birth trauma.
We spend more money on litigation than we currently spend on the maternity services. It's bonkers.
That it's in all of our interests, and particularly the government, to improve maternity services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution needs to happen. We need to start working together.
I know it's a hard time, but for goodness sake, it's the best profession in the world.
Be proud to be midwives, be proud of the job that we do, and continue to celebrate our successes.
Midwives make a difference to women every single day, and let's not lose that. It's more important than anything.
Welcome to Matflix, video streaming from maternity experts. My name is Dr. Jenny Hall. I am the box sets curator at Matflix, a fellow of the Royal College of Midwives and a former editor of The Practicing Midwife. At Matflix, we bring together videos of talks from top maternity experts into box sets to support your continued professional development, study and revalidation. It is a perfect study accompaniment for midwives, maternity professionals, midwifery students and anyone thinking about a career in the maternity services. My job is bringing together the latest thinking area by area so you do not have to. Not only do you get the video of brilliant talks and relevant content in thematic box sets, you also get access to the audio version so you can listen on the commute or while you walk the dog. Plus links to the latest research in the relevant field, government policy documents, the presenter's PowerPoint and more besides. Sign up to Matflix now for the best video streaming from maternity experts.
You're thinking, but I've never read about these midwives in the Bible, and that's because they didn't make it into the Gospels. Why was it that we nurses, midwives, seem so invisible to the doctors, to the media?
An amazing midwife said to me, you can't be what you haven't seen. These are the world's most researched probiotic, and we can say that with confidence because we've done over 300 clinical trials on this little bottle of goodness.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's real trailblazers.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators. Anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Okay, now the first award is... What's
nothing, I don't know.
We have had a 40% caesarean section rate in the National Maternity Hospital. That is major abdominal surgery.
Around 40,000 mums did not return to work in 2022. It's even more relevant if you're a mum who's experienced birth trauma.
We spend more money on litigation than we currently spend on the maternity services. It's bonkers.
That it's in all of our interests, and particularly the government, to improve maternity services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution needs to happen. We need to start working together.
I know it's a hard time, but for goodness sake, it's the best profession in the world.
Be proud to be midwives, be proud of the job that we do, and continue to celebrate our successes.
Midwives make a difference to women every single day, and let's not lose that. It's more important than anything.
Welcome to MatFlix, video streaming from maternity experts. My name is Dr. Jenny Hall. I am the box set's curator at MatFlix, a fellow of the Royal College of Midwives and a former editor of The Practicing Midwife. At MatFlix, we bring together videos of talks from top maternity experts into box sets to support your continued professional development, study and revalidation. It is a perfect study accompaniment for midwives, maternity professionals, midwifery students and anyone thinking about a career in the maternity services. My job is bringing together the latest thinking area by area so you do not have to. Not only do you get the video of brilliant talks and relevant content in thematic box sets, you also get access to the audio version so you can listen on the commute or while you walk the dog. Plus links to the latest research in the relevant field, government policy documents, the presenter's PowerPoint and more besides. Sign up to MatFlix now for the best video streaming from maternity experts.
You're thinking, but I've never read about these midwives in the Bible, and that's because they didn't make it into the Gospels. Why was it that we nurses, midwives, seem so invisible to the doctors, to the media?
An amazing midwife said to me, you can't be what you haven't seen. These are the world's most researched probiotic, and we can say that with confidence because we've done over 300 clinical trials on this little bottle of goodness.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's real trailblazers.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators. Anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Okay, now the first award is... What's
nothing, I don't know.
Hey, welcome to this week's Maternity Midwifery Hour. My name's Sue MacDonald. I'm the curator for the Maternity Midwifery Hour and the Maternity Midwifery Festival, and it's my pleasure to be chairing this evening's session. And we have the wonderful Molly O'Brien with us. Lucky! So welcome, Molly. Now, we always have to do this, and we have to put you on the spot and ask you to share a moment of the week with us, because our audience love that.
Oh, absolutely. I thank you. Yes, I'd love to share that, actually. I did have a moment of the week because I was in London and I was at the Wellcome Institute, the Coming of Age exhibition, and it was fascinating, the exhibition. But there was actually there was two bits of the exhibition really struck a chord. One was a picture of the witches, a witch round her cauldron, and then there was a little piece of information saying that witches actually back in the day when they were burning them were actually healers and midwives and other women who were just looking after their family and having some knowledge about keeping healthy and attending to the important things in life, family and health and food. And I thought, well, there you are. It kind of feels like we're going through a funny period at the minute with what we're trying to do is keep everybody healthy, and we want that. That's our midwifery work, isn't it? The other thing was about health again. It was Born in Bradford, people's research from the moment of birth through your life. And I think it has been done before, but this was in Bradford, in a community, an area where there's a lot of deprivation and inequality, inequities. And it really struck a chord because this is what came up in a lot of the reports that we've had recently about racism, about poverty, about inaccessible services for certain groups of women and their families. And that really struck a chord for me in our work as midwives.
Fabulous. Well, I love the mixture
of the witches.
The witches.
And the Bradford work. And actually, let's celebrate. The Wellcome Institute is a wonderful place to go. They do wonderful exhibitions. They have something there all the time. But they've had
good.
previously, because I think I talked about it on the hour, they had these scrolls that women used to wrap around them. They're just one scroll. I didn't even know these things existed, but this is a place where you can get some really
absolutely. And I saw that exhibition as well. It was fascinating. So yeah, quite agree. This is my new favourite place to visit now if I'm in London.
And they do a nice cup of tea too.
They do.
So thank you for that, Molly. Now we're going to let Molly have a little rest. For those of you who are new, big welcome to the Maternity Midwifery Hour. And I'm addressing this to you because I know we have a lot of old friends, I should say, who are with us and who know the sort of birth of the Maternity Hour. But this year we're in our 6th year of doing the Maternity Midwifery Hour, and we started right at the beginning of COVID-19, the first UK lockdown. And this was really because we felt it was really important for midwives, for student midwives, for people working within the maternity services to be able to have some sort of connection, to actually get as much information and actually continue professional development as they went. So we set this up and we started off with things on well-being and what was going on in the services, what was going on in education to protect students and make sure they got their experience. And we've kind of carried on, and we're obviously not talking that much about COVID these days. We're talking about things of interest and of importance within maternity and within midwifery. Now, if you should have a power cut, don't panic, because everything the Maternity and Midwifery Forum does is recorded, so you can access it after the event. And I think this evening, I say this every evening we do, you will learn something new, and you will learn things that you will want to share with your colleagues. So you can. We're not precious about you sharing. You just need the link, which will be accessible as a podcast on Friday and through the newsletter that comes through, and you can get the whole recording if you'd like. And this is all looked after by Matflix. Now, on the resources that Paul has got on the live Facebook feed, you will see that you have a link to the Matflix, so you can access other recordings, all the Maternity and Midwifery Hour, and also some of the festival materials. And that's a really good resource, and I'll really praise it for you. For those of you who are doing a dissertation, any research, practice development, wanting to do your revalidation, really good resource, because our lovely Jenny Hall, Dr. Jenny Hall, does pull some of the presentations in nice little chunks together with some reflective activities, which is perfect for those of you doing a revalidation. So really look after that if you can. The only risk of accessing these presentations is it is a bit addictive, and you can find time goes by and you've watched an awful lot and learned a lot, but the time, you haven't done the ironing. But never mind, we won't worry about that. And I will say a big take care of yourselves, because I know, and I'm sure Molly will refer to it as well, it's a difficult time in midwifery, and it's a difficult time being a student midwife, facing the fact you may not get a job immediately. It's difficult for midwifery, full stop. So look after yourselves and look after your colleagues, because we all need looking after. Look out for each other. Really important. Now I'm gonna refer to this book, The Roar Behind the Silence. Sue Down and Sheena Byram edited it, full of really good resources and information. And I think this is particularly pertinent in today's midwifery. So beg, borrow, maybe not steal, beg or borrow a copy and have a look, because it's a really good dippy-inny book, but then there's lots and lots to get there, and it's a bit addictive too. So there we are, that's your bedtime reading. Another bit of reading is the Nursing and Midwifery Council consultation on proposals to change the nursing and midwifery practice learning education standards. That closes on Friday on the 17th, but have a look at it, have your say, put in your views, and then you can't complain if they don't do something. There's also a new strategic plan for 2026 to 2029 from the Domestic Abuse Commissioner, which I think anyone who's working within domestic violence, domestic abuse will find useful. The other thing is it's the second annual South Asian Baby Loss Awareness Week this week. And this is founded by Tommy's supporter and miscarriage advocate, Asaya. And it means there's a lot of activities and information going on. So have a look on the resources to Tommy's, you'll find more information there. And I'll say a little positive, well done to Emily Kent from Luton and Dunstable for being a finalist as Nursing Times Midwife of the Year. So good luck with the next bit of it. And do have a look at the resources for more information. Now, tonight we're going to look at movement, and I think on the discussion we put on the information for this evening, we've talked about the fact we all learn about the female pelvis, the fetal skull, and the mechanism of labour. And it used to be always the mechanism was quite flat. Now you'll find most of the books will illustrate women standing or in squatting positions for the birth, which is quite right. But we don't always understand the other bits around the mechanism and the body, actually. The body is a marvellous thing. And there's a lot of influences like factors like exercise and movement, which may have an impact on the progress of labour and birth. And to share her knowledge of this and her passion for this topic, we have Molly O'Brien, who I'm delighted to introduce, very experienced midwife, over 28 years in practice, more of 20 spent working full-time in clinical roles within the NHS. She's a birth preparation teacher, associate university lecturer, and the creator of some very specialist education programs in biomechanics for birth for midwives and other birth professionals. She's got a marvellous website full of wonderful information, also on your resources sheet. So welcome, Molly. The screen is now yours, and thank you so much for coming this evening to share your movement.
Oh, thank you. I love that, Sue. And indeed, you are correct that my subject was and is tonight going to be talking about movement in the birth room and what we can do to facilitate straightforward birth and how that baby comes through the pelvis. But I have expanded it. As Sue and I were speaking earlier at 2 o'clock in the morning, my mind's going and thinking, actually, I need to put pregnancy in there. It is something that's also incredibly important as far as movement's concerned. And and again, related to our work as midwives, as public health practitioners, but pregnancy is actually about maintaining health as well. We want to support those women and their families through good health and address some of the inequities and inequalities that were actually highlighted in some of the recent reports. So I felt like I really needed to get that into tonight's presentation. So it's about pregnancy and labour and, of course, in the birth room, what's happening in there. Pregnancy, moving throughout pregnancy increases health for mother and baby, and a room that supports movement is a room where birth physiology is more likely to unfold. I have got a few references there. I will be alluding to some of these references throughout the presentation. But here is some of the health issues that are needing urgent attention. We know this, but they were highlighted in both the Ockenden and Amos reports. So, gestational diabetes, hypertensive disorders, including preeclampsia, maternal mental health, antenatal and postnatal, inequities in outcomes by ethnicity and deprivation, and obesity-related complications, isolation, and lack of a relationship-based model of care. These are really big issues in our world as public health practitioners who care about the health of the nation. No mean feat and no small remit for us. And I think it's really important that we remember how expansive our work is. So imagine a drug that cut gestational diabetes and preeclampsias by around 40%. That would be pretty awesome. And it cut antenatal depression and actually postnatal depression too by roughly 2/3, narrows health inequalities and doesn't have any side effects. That's pretty awesome. And it's not a drug, it's movement. It's movement, it's connection, and it's community. And that is what midwifery is about. We impact health in the way that we actually provide care. Unfortunately, we're not doing that at the minute because, again, highlighted in the reports, our models of care are fragmented. And I'm hoping that we can start, when they're talking about redesigning maternity services, that we can dream big about what exactly it is we like to see, knowing the evidence, knowing the power of midwifery, that we can actually provide excellent care. And that drug that is not a drug, but actually movement and connection and community relationships. And unfortunately, excuse me, physical activity declines during pregnancy. And most women actually become less active as the pregnancy progresses. Between 60 and 80% of women reduce physical activity during pregnancy, and only between 50 and 30% meet recommended guidelines, which is 150 minutes of moderate activity per week. And that's evidence-based, and we're not doing that. Pregnant women are not meeting those requirements for health. 50 to 70% of our waking hours become sedentary as pregnancy progresses. As a nation, actually, as a population, we have become more sedentary, and I wonder if it's a modern thing, and I think we are much less active than our previous generations. But even more so, I think, since COVID, we became more sedentary. We're working a lot more from home, and everything seemed to shift at that point. So I think it's even worse in the last 6 or 7 years. Midwives want to advise on movement. We understand that it is a good thing to move, but we have a gap in our knowledge. Now, I was actually going to put it's probably going to be too complicated, but like a little Mentimeter word cloud up, and to say yes or no if you have seen or use, not just seen, but actually use the physical activity for pregnant women poster that you can see on the screen right now, and that's a medical officer recommendation. It's all evidence-based. It's an infographic, so it's quite easy to understand. We need to move. We can climb the stairs, we can walk, we can do yoga, dance, and swim and cycle and do lots and lots of activities that are just generally part of our life. And also a bit of muscle strengthening would be very valuable as well. And we're not doing much of that at all, as you saw in the previous screen. This would make a huge impact if all of us midwives too, we're working very hard, but we're not necessarily moving a lot. We're standing, we're writing, we're standing by beds, and actually movement is really healthy for all of us, and not least those pregnant women. So do you know that pregnancy poster? Do you use it? It's downloadable. You can have it on your phone. You should have posters of it in and around where women are hanging out in antenatal clinics and so forth, because they can see that and you can refer to it in your busy clinics. I know you haven't got a lot of time, but in fact, that is part of our problem. We haven't got a lot of time to refer to our work, which is salutogenesis. And salutogenesis is the maintenance and sustenance of health. That's where we are rooted. And unfortunately, an awful lot of our work is taken up by risk assessment. Now, I'm not saying that risk assessment is not a valuable piece of work. Of course it is, but it's kind of overwhelming, actually. And it's not necessarily bringing the results that we think we want to see. So again, that needs to be redesigned. What is it we're actually doing? How are we spending this time with the women? What information are we gleaning and giving? Our knowledge is very poor. We don't really know. We haven't really had much training. We don't cover it in our curriculum. And that is detrimental to the information that we can give. So we're feeling less confident and a bit out of our depths. We've also got fear in that area, as we have fear in our work. We know that we have anxiety, concern, fear that we might step out of our remit of what are we doing? Do we know this? Well, this is very much in our remit, but we don't have the information. And as DeVivo and Mills in 2019, after they explored this area, they said, advice is often given based on common sense and our own experience, which is okay, but it just depends on what information it contains. A lot of it was based on women as being very fragile, must take care, don't do too much. And a lot of the information that we had came from nothing. It wasn't actually based on anything. And we're getting more information now, which is brilliant. Here are the gains. This is what we know now. And there's Dr. Margie Davenport she's actually created guidelines. She's in the University of Alberta in Canada, and she's actually created guidelines for antenatal activity as well, and looked into it, and actually did RCTs in this area. So very, very powerful knowledge coming from those studies that are telling us we can lower our risk of gestational diabetes if we are active. We can lower the risk of high blood pressure and preeclampsia. We can improve our mood and mental well-being. That means we're actually reducing depression, and that's antenatal and postnatally as well. We have less back pain, less pelvic pain, and less disturbed sleep. And it also has an impact in the birth room, shortening the first stage of labour, and with fewer interventions required. And for the baby, who would think they're going to have benefits too? Healthy birth weight, better infant motor development, and it supports fetal heart and brain development. It also has a lower risk of childhood obesity, and it's safe at every stage of pregnancy in an uncomplicated pregnancy. We don't often think of the benefits for the baby, but it improves their metabolism too. And of course, this is related to the health benefits that the mother gets. One of the things I did actually, born in Bradford, do have a look at that website. It's absolutely amazing, full of really good information. And I hadn't really thought, and I know there's more studies out about this, food security, and there are a lot of women who are concerned about food security. And when you have those issues in your life, for those mothers who are feeding families, they tend to not be eating very well themselves, and they tend to go for high sugar just to keep them going and giving them energy. And of course, that's going to have an impact on their growing baby. Stress in their lives attached to that food insecurity, but also just in their lives, especially in those areas of deprivation, because you're always worrying about something, and it has a huge impact on the growing baby. So this is why we need to use this evidence and put it forward to as much as we can when the redesigned maternity services be heard, be shouting out that midwives actually impact public health. We are public health practitioners. It's not just being in the hospital, it's actually being in the community, and that matters. And I really implore you all to be shouting out about that. Immobility in the birth room, big deal, big deal. I'm getting my postmenopausal wrath going here. I cannot believe there's so many women who are actually not mobile in the birth room. It has gotten worse, and it has a big impact again on women's physiology, on their autonomy, and on healthy birth outcomes. This is really big impact. And of course, it also has an impact on the quality of midwifery practice and student midwife confidence and learning. The women want to. we've got evidence. Shori et al., they had a look at that. What do women actually want? Are they keen on doing this? Well, I know that things have changed a little since 2022. Again, we've got more fear. Women are not accessing midwives for their information. A lot of them are getting it on social media, and they're making choices from the information they get on TikTok, which is, some of it might be quite good and a lot of it will not be. And this is going to impact on their decision making and feelings about what they want as they give birth. But this showed that most women do actually want to move. And who would blame them? You're going to feel more comfort when you move around and walk in labour. It's a natural response to pain, and it's repeatedly interrupted by clinical routine. We always want women to just pop on the bed for a moment because we have things to do to her. This is not that we want this, it's just the environment that we are actually working in as well. And partners are influential in this area too. They play a crucial facilitating role. If we are actually giving high quality birth preparation classes, we would be including information so the partners understood the benefits as well, and they would be really influential in helping that to happen. And we have an issue, don't we? Women have to ask permission to move. I really struggle to get my head around that, but they do. Am I allowed? Am I allowed? And we're all doing that. I'm going to refer back to, well, I mentioned it very briefly. I'm not saying that we're witches. I'm just saying that women who actually look after other women, who look after families, who are taking control over their health, were regarded as witches, and they were oppressed because it didn't fit that society. And we are working as women, attending women in their births, and we're not heard either. We've got feeling unheard. We've got permission culture. This actually is for both staff and the women we attend. And that is not me just saying it off the top of my head here, because I think that, I know it, and it came up in the reports as well. So it goes right down to movement. Can I move? Is it okay if I get up and move around? And we should be facilitating that, because we understand that this is really important for women to have that and to be heard. They're feeling disempowered and they lose control over their own birth. Big deal, isn't it? And we can make those differences, and we need to stand up and be heard, make ourselves heard in this way, because we are advocates for women. And it's hard. I know. I'm feeling for everybody. It is challenging, but we can do it in different ways. I'm going to show you how that works in a moment. So it's one of the most profound experiences of women's life, and autonomy is not a nicety. It's actually a legality and ethical and a professional obligation. So we're attaching women to a monitor. Please distill. We need to make sure your baby's safe, and we need that piece of paper to come out pristine, because we've got anxiety about it. And that is that's a risk to manage. We have staffing pressure, where we're looking after too many women, too much to do, overseeing too many obstetric interventions. And therefore, we're discouraging the women from going into the pool, or getting up and moving and giving birth, or labouring around on a ball and maybe on a mat on the floor. And this is giving us anxiety. We'd rather they were maybe just on that bed. And women don't know. And again, this is education. We have to educate. When I'm a birth preparation teacher as well, and I ask women, where do you see birth taking place? And they say, on the bed. Of course, that's what they see in the media. And they don't know that they can say, well, I don't want that. Many of them just do not know their rights. And this is our job to make sure that they understand that. And we're not alone here. When we want to make changes, when we need to make these changes, redesigning maternity services to work for these women and their families and their partners, and that will work for us too. Remember, our working condition is the women's birth environment. So culture conditioning, as I said before, where women are just, that's where they see birth. So we need to educate them and let them know that actually movement is a really good idea and they want to do that. Continuous monitoring is getting in the way. Please, if you don't know Kirsten Small, please find out about her, because she is doing a big job to address the issue of electronic fetal monitoring and continuous monitoring that holds women down, that brings fear in the room and does not improve outcomes. So that's Birth Small Talk. If you haven't heard of her and her work, please look at her website, Birth Small Talk. She's got very good courses for not only for the women and their partners, but for the staff as well. So we are up to date and actually looking at this monitoring with a different eye, different lens. Epidural analgesia is, of course, a very popular analgesia. Do you, in your workplace, have mobile walking epidurals that allow movement? Some do and some don't. I think that's unacceptable. We have got a dynamic physiological process taking place, and it is possible to have a walking epidural. There are some hospitals where women are not even catheterized. They get up and go to the toilet. They can move around. If that's not happening in your area, then get a bit cross about that, because this is going to make a difference to those women being able to have that movement and certainly be able to rock and get on all fours and move around. But we can still use some tools that are really helpful. Peanut ball use is all still possible. It increases pelvic diameters. If you don't have peanut balls, get peanut balls, because they are wonderful, a really supportive tool. And our language, and I know we have compassion fatigue, we have moral injury, we have cognitive dissonance, and that was also picked up in the reports. But our words shape what feels possible. So if we can start to speak in a way that actually supports this woman to have what she would like to have movement, to encourage her to move and feel more comfortable, then this is going to be pivotal. And the room is not giving any impression that movement can take place there, because that bed dominates, and a bed that's dominant in the room denotes passivity. It sends that message. Can we move it? We should be able to. And if we can't move it, then we can change its shape. Give an impression of movement. When this woman walks into that room, she must be able to think, you know what, I think I could actually maybe sit on that ball. I'm hoping that you're all giving her birth balls, or not giving her birth balls, but recommending those balls as soon as she's pregnant. Say, get a birth ball, sit on it, move around on it, drape yourself over it, enjoy what that movement brings you, as well as it in maintaining pelvic mobility and reducing back pain. That's giving a message all the way through pregnancy. And now she's gone into the room, there's a birth ball. And she's familiar with that, and she knows the comfort that brings, so she can sit on it, and that improves mobility in the birth space. And we've got a growing evidence base that's telling us, as if we need evidence, but yes, we do. We need evidence for everything, and we need to make our impact about this area. We need to say, yes, we know that this actually shortens the duration of labour. There is less epidural analgesia. Now, for women who want to use an epidural, there's no issue. But for those who don't and maybe struggle with the intensity of the pain in labour, they will actually do better if they can move in that those are the women I'm talking about. I'm not talking about depriving anybody of an epidural if they want one, but for those who want to move around, they will find that they don't really want to have that epidural, that they may have started thinking, oh gosh, it's more powerful than I thought. And it also lowers the risk of cesarean section without epidural in place. These upright positions, they carry a clear, consistent advantage compared to recumbent positions. Tinker et al., and these are really up to date. This is 2026. There's a clear association confirmed between upright position and second stage, in active second stage, and increased rates of physiological birth. And physiological birth, as we know, brings health benefits. This is about health. This is not about ideology that has actually been raised in the media and in some social media maternity commentators, where want women to stay healthy and whole. And actually physiological birth brings that. That's why we're keen on it. And those who birth physiologically are more frequently using all fours position or a birth stool. And those who had instrumental births were more often in a semi-recumbent or lithotomy position. So this has an impact. It is a direction of effect consistent across both stages of labour. So this is not ambiguity. This is good quality evidence, and the challenge is implementation. This is a reality of practice. So despite that good quality information, the last 24 hours before childbirth, 80% of the time spent in non-flexible sacrum positions. So you have the sacrum, which can move a little bit. I mean, it's not loads, but it's enough to make more space for the baby. And we know that pelvis expands. And yet these women were actually mainly in those non-flexible positions prior to in the 24 hours leading up to the birth. And at the birth, more than 90% actually gave birth in non-flexible sacrum positions. This is a big issue. This is a really big issue. Most women are giving birth semi-recumbent. That compresses the sacrum and reduces the possibility for movement, for expansion, to make birth a little bit easier. So that's the gap we've got to close. Got to consider what the heck is happening there. We can't ignore these numbers either from Tinker. Every 10% more time upright increased the likelihood of physiological birth by 26%. And every 10% more time supine, there was a 30% increased likelihood of instrumental birth. It is quite astonishing that this is still happening, that women are still very much semi-recumbent, giving birth on the bed, not moving, when we have these figures showing us the benefits that women can give birth more easily if they can move. And of course, I'm not saying we should be prescriptive about this. Women should be able to choose their own birthing position. That's really, really important that they do that. And sometimes it is supine. We've all been there, I'm sure. She's been on all fours and then suddenly she chucks herself around and lies on flat on her back. And that's because it felt right for her. And that baby's coming through her pelvis, navigating that pelvis. And of course, we've got shoulders coming through and, you know, everything moving. And so that was right for her. But we do have this information here that really supports movement in the birth room and the possibility of changing position. So it's not just about one position, it's changing and moving, and it is cumulative. And of course, if women are lying there, immobilized on the bed, attached to monitors, drips running, midwifery becomes less skilled. So what we do if we have a woman who has not got, is not attached to a machine for monitoring her baby's heart, or on drips, or isn't immobilized with a dense epidural and she's moving around, we need that understanding of how her pelvis opens up, that's biomechanical knowledge, how our body works. What about that beautiful articulated architectural structure, the pelvis, which is really complex and beautiful and works really well. We need to understand that so we can honor it, respect it, and help her to be more confident in moving. And we need that confidence too. We need to help facilitate that movement. We can use functional assessments without relying on vaginal examinations. That's another issue. I can't go down there because I haven't got enough time, but that's another issue, isn't it? Midwifery is about skilled work and skilled assessments, and trusting in physiological process. That's not like wildly trusting even when things are going wrong, of course not, but you need to be able to understand patterns of normality, of normal physiology that unfolds, and there's a variety of patterns. If we don't understand them and recognize them as being normal variety, how can we tell when it's gone awry? And that's part of our remit. We need to be able to recognize that. So actually understanding and trusting that physiological process is important, but not, of course, ignoring it when it goes off kilter. And environmental adaptation skill, that's about working around what you've got in the room and being able to work with different movements, different positions. And that's something we're struggling with. Most of the bed-based births are including CTGs. I've just talked about that, IVs, medication protocols, documentation, escalating intervention management, and handover and referral pathways. We've got a very much a different kettle of fish when we're talking about women who are bed-based birth. You know, that's a very different scenario altogether. And yet that is the one we're most familiar with. And I will actually say that's more obstetric nursing. We're more overseeing obstetric intervention. And I love obstetric intervention, no doubt about it. I think it's wonderful. It saves lives. But right now, nearly everyone has that. It's very rare not to have that intervention. And that's our work now has been placed in that arena. And we don't have those skills. We're losing the skills to facilitate active birth. We're feeling a little fear with that because the bed has become the default. What's our generation of student midwives learning when movement is restricted? And they're very, very keen. They want to learn, and they learn in the university, and they come into the placement, and this woman is in a recumbent position, semi-recumbent. Some midwives and many student midwives have never attended birth in any other position than semi-recumbent, and actually worry when the women go onto all fours. So this is, we need to help these students, but we need to help ourselves too, because a lot of qualified staff are feeling this lack of skill and experience to gain confidence. So let's not just accept this is what birth is like. This is, women are choosing this and not choosing it. They're just feeling fear as well, but we need to educate and encourage so they understand what they can do in the birth room. We have this that's keeping it going. This is understanding the system. The forces maintaining immobility are real, interconnected and systemic. It is not individual failures. Again, this has all come out in the reports. We have risk aversion and litigation. We have staffing pressures. We have the medicalisation of childbirth. And again, I'm going to make it very clear, I am not anti-intervention. Of course, bring it on when women need it. But every single one? Really? I teach and I ask a question about oxytocin, synthetic oxytocin, every time I teach, and I've taught thousands. midwifery professionals, midwives and obstetricians too, in the NHS. And when I say how many women are on using synthetic oxytocin in your maternity units, the answer is the same every single time. It's nearly everyone. So we've been through some of this already. Environmental design. I mean, we're not going to get brand new units, but we can make that room. Bring your midwifery with you into the room and make that room, make it so it supports physiology. It doesn't stop anything else happening, but supports. Everybody deserves to have their physiology supported. Everyone, no matter what's going on for them, because it is a really it's very powerful, and it can help them stay calm, and it can even reduce those emergencies happening because their physiology has been supported. So macro, meso and micro, policy and commissioning and system design. These are national guidelines, environmental investment. We are underfunded. This is part of the problem. Underfunding is part of the problem, no doubt about it. And again, this has come up. We are under-resourced and understaffed and underfunded. We need institutional culture and leadership in education. That's the meso level. We got the micro level where we are as individual midwives at the moment of care and what we can do, and we've just talked about some of that. I feel that I'm going over, so I'm going to just flip through this. National guidelines must include mobility. It's not an optional extra. Birth is a dynamic physiological process. Actually lying down and not moving is not part of that. It's you can still have your epidural, you can have that, but it needs to be able to allow some movement, and that's really important. And we need that capital investment. And you know what? Where are the balls? Where are the mats and the bars and the low lighting? Some places are getting that, but not every place. It's almost like, well, that's optional. And it's not optional because you don't have pumps and all the medical equipment optional. That's all available. But to support physiology and optimize physiology, those things aren't available. It's as if it's an added extra. And the safety inquiries must not just become surveillance only. We've got this drive to increase monitoring, but monitoring alone is not creating those safer pregnancies and births. We have the evidence to support what I've just said. It's also about restoring confidence in physiological birth and creating the conditions for it to occur. Visible leadership. These are all the things that we've heard about in the reports. Embed biomechanics in training, and actually I'm very pleased to tell you that I've actually put some proposals into universities that are really keen for this to be part of our training. It is a gap. We are still learning. I'm going to finish on this really quickly, but just to say that we are still using the Caldwell-Malloy pelvic classification from 1933. Then it was adapted in 1938. That is just ridiculous. It's nearly 100 years old, and we lean in on the gynecoid pelvis. That work that they did was actually set in racism. It ignored the anthropoid-shaped pelvis, which most of the Black American women in that study back in 1933 had an anthropoid-shaped pelvis. Now, we allude to that in our training, but we don't take it all the way through about what that actually means. And it means that the mechanism is different because the shape is different. And that is expressed in the patterns of labour that are different for those women who have that shape of pelvis. And some of it might be white, and many of them will be black and brown. And that matters. And that's why we need to update ourselves in fascia. Fascia is a new thing in our world. So we need to update ourselves in the biomechanics of the labouring, of not just pregnant and labouring women. And in simulations, rewrite those guidelines to reflect all this, redesign student placements placed with mentors who actively facilitate movement. Oh, sorry. And there was one, about not mocking a midwife who is keen to help this woman maybe get in the water or on a mat. That this is actually about physiology, and what she's doing should be celebrated. I'm going to just move on quickly because I do know I'm over, and I want to have questions if anybody's there. And also the football's on, I know that. But I'm going to just, you can see this is what we just talked about. Make that room fit for purpose, and let the woman know she can move here. Use empowering language. It's not about just you're only 3 centimeters, but it's still early. Let's use this time well, and so on. And model for your student. Let her know what we do as midwives who facilitate straightforward birth. That's the cost of keeping women still, compromising physiology. Oops. Oh, I feel like I missed something. There was, I'm going to say, I think there was a slide that was missing. It was actually telling us what was happening in some of the areas. Now, the Ramen project is a really, really good one. This is in the sort of in the community relationship-based area of our work. And Faiza Raman, she launched this project where she gathered women from ethnic minorities and to give them cultural support. And she's got walk and talk groups and lunch clubs and antenatal clinics, and that's classes, and that's really important. So making those connections. And she's also we've got other walk and talk groups that are around. We've got This Mum Moves from the Active Birth Foundation. Again, really, really great website. Have a look at that. And there was pregnancy circles. We haven't got a lot of time. We understand that, and there's not enough midwives, but there's been a lot of work in City and St George's University has done a lot of work, as has others. Octavia Wiseman did some research with other researchers there, showing that pregnancy circles of small groups of 10 to 12 women who are in their local community, where they're living nearby, coming together, getting information together, can actually really optimize the time and create that connection that is so lost in our community. So let's think creatively. Let's actually let's be part of redesigning our maternity services with midwives at the centre as public health practitioners. So do consider, what is it you're doing there? What message does your birth environment send to the women? And how would a student midwife learn from you if they spent every shift with you? And what are you doing? And what do you think about strategies to help support pregnant women, new mothers, and families who are feeling a little isolated, a bit lost? And this is our work to step in to that. Thank you.
Molly, my goodness, you're giving us a little bit of a challenge there.
Yeah,
which is a good thing. And I was thinking, I know sort of things like Active Birth with Janet Velasquez, which is quite an old book, but I can remember that coming in and reading it and getting so excited as a fairly junior midwife and trying some things out.
Exactly.
And actually, people were quite receptive. Women were very receptive. And I can remember some of my colleagues kind of said, "Oh, Sue is she's the active one."
You see, that's what I'm talking about, Sue. It's like there's a few of us. Oh well, she does that, but we should all be doing that because it's midwifery. And while I understand there's some complexities, I do get that, and there's brilliant that midwives actually learn that too. And some of them are really in their element in that area. Far too many are in their element of, now I'm just looking after this woman on this bed. I would not know what to do if she moved, and that is where we're at. So it's really extreme, isn't it?
Yeah, but I think you're right, and I think it can get a bit scary. It's like when you've been on holiday for a while and you come back and you think, oh, I've forgotten what to do, and of course you haven't.
Yeah, no,
because once you're there and you're thinking,
yeah,
midwife, it
yeah,
comes back. And I think even having a few midwives or students, because the thing, what you say about students, absolutely right, and students are keen. So you out there, students, this is your chance just to maybe work with your midwife and say, oh, I learned this new thing last night, really interesting. Da, 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 da. We have some questions. I have a question from Khalifa from Ethiopia. Hello, Khalifa.
Lovely
to welcome you here, and thank you for giving us a question. Now she's saying, how about fetal distress in the upright position?
Fetal distress in upset. Well, one of the things that we do usually, if we think that if there are signs that the baby is struggling, that there's fetal distress, is actually changing positions, isn't it? And that's an automatic. I know that we do a lot of that. So if the baby is showing signs of distress because mother is in an upright position, and that might be that there's something to do with the cord, it could be cord compression, but we just change position.
Good point. And I think also you were talking about the sort of time quite a lot. But isn't it so that if you have an active birth, it tends to be a wee bit faster?
Oh, it does. It shortens the duration of the labour, and lessen pain. I mean, it is just women who, when we know, for example, where active birth is more likely to take place, is going to be at home births. For example, we're not expecting women to be there for days on end. They're just not. They're usually and usually that's a sign that something's not quite right if there's prolongation there. But they give birth much more easily and it unfolds more easily at home. So we understand that, and that's clear. I mean, the thing is that we know right now most women, it's such a challenge, isn't it? Because midwife-led services are being reduced dramatically. So we don't have so many birth units, midwife-led units that are open. We don't have so many home births. So choice has gone out the window for women, which is a travesty, actually. But also those fact is that those are generally speaking faster births, because they're because it's mind and body, isn't it, Sue? It's not just all about body, it's about everything. We're not mechanical bodies. I talk about the mechanical element because it's ignored and neglected. So I'm just putting it in there, but I'm absolutely understanding that it's a whole person. So what goes on for this woman is also what's in here, and she's in a safe environment. That's the key, isn't it?
Yeah, absolutely. And it's amazing. Actually, you're talking about environment, which I found really absolutely. We have the bed in the middle of the room, and it's very alien. But actually, it's amazing what a difference a midwife who's smiling, a midwife who's there, and interacting will make the room cozy.
Make it and when we
thing here,
I know. And when we say cozy, it's not an added extra. It's that coziness, and it brings security and safety and privacy, all the things that we understand supports physiology, which I'm talking about oxytocin, the production of that, for it to function well, for the woman to be able to change position, to be naked and to be on all fours is such a vulnerable position, and you need to be in the right environment to do that. And so our birth environments right now are not supporting that possibility because women are not feeling safe.
No, I mean, I think there's a lot of focus on safety, but I think you've got it. Not necessarily the sort of psychological safety.
Yeah.
And Diane Garland, hello Diane, is saying the best monitors are midwives.
Yes.
Quite right too, Diane.
Yeah, absolutely.
And then there's quite a lot of comments. I think you've kind of, people are really chewing over what you've been saying. Jan McCarthy, hi Jan, says, thank you for a wonderful, informative talk. Sorry, I have to leave now. Well, you can catch up later, Jan.
Yeah.
And you must.
Yes, yes.
And then Diane's having another bite at the cherry here, Diane. What's sad, when units have spent a lot of money on equipment which is not used. Fancy equipment is not always required, including some birth pools. And that's from someone who's the water birth expert.
No,
Thank
it's
you.
absolutely true. And again, we talk about this in my course, and we're talking about birth balls. Do you have them? And you say, yes, they're all in the pool room, in the pool, because it's not used. It's almost like that's a storage place. And that is so sad, isn't it? Absolutely. And that's because we're not appreciating the benefits of movement and understanding it is. Here we go again, that postmenopausal wrath. But our work is not soft and fluffy. And it's being put out as if, oh, well, that's just an added extra. It's soft and fluffy. We've got the hardcore machine here, and this is going to save lives. And yet it's not. Midwives save lives. You just need to look at Mary Renfrew's wonderful poster and her presentations to show the impact that midwifery has on safety and reduction of preterm births and stillbirths when we're actually able to do it properly.
Yeah. Good point. Now, I've got a comment from another one from Khalifa from Ethiopia. Hello, Khalifa again. She's saying the most informative talk, but what is most difficult, needs material CTGs, knowledge for basic physiological change. I'm not sure if this means that I think you did say, Molly, that some women will need additional support. And I guess, well, what would you do for a woman that has to be on a CTG monitor? I'm not sure if that's what Khalifa exactly means.
Yeah.
But there are women who want. There are women who want a monitor, or who may need it. So
absolutely.
What can we do to make them be more mobile?
Well,
I'd love to set you a challenge, Molly.
Yeah, no, it's fine. It's a telemetry. So telemetry, wireless monitoring. So, I would advocate for wireless monitoring while we have the conversation about the research that underpins or not electronic fetal monitoring, because right now it is not actually that clear that it's helping at all. Bearing in mind that this was brought into our birth room 60 odd years ago, with I believe that the person who brought it in actually had some shares in the actual making of the machines itself.
We're getting a little bit political here, Molly.
I believe so, and I might be wrong. I'm happy to be wrong about that. However, it was with the remit that this was going to reduce cerebral palsy rate, and it never did that, and still has never done that. So it's the evidence. Again, I'm going to say Kirsten Small is a woman that you need to look at. Her work, Birth Small Talk, intelligent intermittent auscultation, has the same benefits and without the risks of those electronic fetal monitoring CTGs. While we're having that conversation, because it's entrenched in our work, and it will take a wee while to have a look at that and find out what it is we need to do to keep women safer. Intelligent intermittent auscultation should be beginning to be rolled out because it's very effective. And while we're doing all that other work, telemetry, which is wireless, enables women to get in the pool and to move around.
Fantastic. That's fantastic. Zara, got another question. What would be the best way to try and introduce more cozy into a labour ward? With management. With managers.
With managers.
Well, there's midwife managers who would be very receptive, actually.
Absolutely. They can. And I understand why you've asked that question, Zara, because we feel blocked when we want to do good things. And that's part of not being heard, isn't it? And it's part of what the reports came up. Nobody's listening to us. But there are some good practices in in some hospitals. Stoke Mandeville have an active birth project, which is brilliant and really effective. And they took it very seriously to create their rooms that supported physiology. Now, without compromising on care, of course. This is, I have to keep saying this because there are some who think that if we do our work, then we throw caution to the wind. Of course we don't. We're doing this carefully. But by they took it seriously by setting up and making sure that every room was put back to the same arrangement when it got cleaned, just the way an epidural trolley would be once it was used. So they had a QR code, and that was taking it seriously, that room now is fit for purpose. It allows movement. It is supporting physiology, with the lights are a little low, with the privacy, and please knock before you just come in. And again, this is respectful care, isn't it? That is the kind of care we're talking about, is respectful care. So women feel safe, have a private environment that is theirs, and they can move, and the low lights, and we're not going to change it overnight. Some rooms just can't get rid of some of the equipment because there is nowhere else to put the equipment. I said, all right. Oh, excuse me, my husband it's like being back in COVID. Luckily he had trousers on.
I can take them off.
Don't you dare.
I'm going to go.
5 minutes to dinner.
Oh, it's like 5 minutes to dinner. So anyway, I don't know. I'm waxing lyrical about all that again. Whatever it is, I was saying that yes, we can make rooms that work for those women and respect them as human beings, and give them care that is fit for purpose when you're having a baby. That can be done so simply, and it doesn't need lots of money. It just needs the will to do it. And I know that the question was, how are we going to get our managers on board? Well, quite frankly, I'm so disappointed that might be an issue, and I understand it is probably an issue. It's about leadership. Yeah,
I think there are some midwife managers who will be very receptive. I think
they will be. Find your person in that.
Absolutely.
Yeah.
Now I know. Hello, audience again. This is the quickest hour in the week, and I could listen to Molly forever, and you've come up with some fantastic questions. So thank you so much to the audience for joining us and for coming up with these wonderful questions and very thoughtful thoughts. And I hope do use this, share it with your colleagues, and maybe have a chat over coffee time or over lunch. Have you sandwich lunch in the restroom? Though I know that's sometimes a running feast, isn't it? But start talking about it. What could you do? Is there, and there will always be some donations somewhere that you can buy some. Now we need to know a bit more about these peanut balls.
Oh, yes.
So, Molly,
yes.
you're going to have to come back. I'm sorry.
I'll be delighted.
We'll have to let you have your supper.
I will.
Or your husband will come back rampaging. And apologies. Thank you so much. I want to say a big thank you to Molly for joining us this evening and giving us a really positive presentation, thinking about how we can change but keep safety, and that safety physiologically and safety psychologically for that woman and her baby and her family, because that is at the heart of all that we do. And
it really is.
The physiology, the movement, that makes absolute sense, doesn't it? And I think I'd like to know more from Molly about how this might help us midwives as well. So that might be featuring in a further episode. So later point. Now remember, you're going to have this. You'll have this recording from the newsletter. You'll also have this as a podcast for those of you who like to listen to it at 6 o'clock in the morning on Friday. That's fine. But in the meantime, we're taking a bit of a break because it's sunshine and everyone's going off on holiday. So we're coming back. We will be coming back in September, and I'll be wheeling in Molly, whether she likes or not. We've got to know about the peanut balls. We've got to know about movement and midwives because it's really important. But in the meantime, you, the audience, have got the opportunity to access some of the Matflix presentations that have gone over the last series, and also you can have some time to read. Oh, look what a nice book I've found.
Oh,
maybe
I love
reading
that
one
book.
too.
I've got it behind me. Yeah.
There's many that we might have to look at active birth as well.
Mm-hmm.
And in the meantime, I'll say, take care of yourselves. We'll see you very soon. If you have ideas for us of things you'd like to see and hear, let us know. I know you'll want to hear more about Molly because I know I do. So you haven't got a choice, actually. We've got to have her back. And in the meantime, take care of yourselves and see you in September. Thank you again, Molly. Take care.
Thank you.